All right, so we're going to begin our discussion on the skeletal and muscular systems. These two things are often grouped together and termed the musculoskeletal system. Um, Starting off, we'll be looking at the skeletal system, and then we'll move on to the muscle, since muscle pretty much exists to move the skeleton. So, starting off, bone. You'll primarily see the term osseous or os associated with bone, but really it's a very hard tissue. It's classified as connective tissue. It's going to be a dense connective tissue, at least in adults. In younger individuals who haven't reached skeletal maturity, which happens sometime between the ages of about 18 and 21, 22, there is going to be a little bit more collagen type content, but we will talk about some of that later. So really, everyone thinks about the skeleton as kind of just being the support network for the body, which really is kind of its most basic function. But in combination of working with the muscular system, it allows for movement. Now, another really important thing that is easily overlooked is our bone actually produces blood cells. All right, it does this in the red marrow that's contained in the medullary cavity of the bone, and don't worry, we'll look at how bone is structured, what the medullary cavity is, etc. here in a few minutes. Another important thing is that it helps store fat. That is yellow marrow, which again will stay in the medullary cavity, and marrow can shift back and forth between red and yellow forms. It's sometimes it's normal, sometimes it's pathological. There's many different reasons, etc., etc. But this is important because many of the hematopoietic stem cells that we have, they're produced in the bone, right? Our hematopoietic stem cells hang out in bone, and they produce every type of blood cell that we have. That's the red blood cells, all of the white blood cells, to include the lymphocytes and leukocyte lineages, and they produce the thrombocytes, which, as we all know, fall apart to create platelets. So, with all of this in mind, it's also important to recognize that the skeletal system serves to protect organs, especially when you look at our thoracic and abdominal cavities. We have our ribs, and even with the skull protects the brain, right? So this same kind of concept applies throughout the body, where bone can serve primarily as a protective structure. So moving on, the normal average human will have 206 bones. There's many different types of bones. It is somewhat common to have, for the average person, to also have an extra one or two bones. It's a very standard developmental thing. But moving on, we got basic classifications. So the first one is our long bone. That's going to be something like our femur or our humerus. There's short bones. So when we look at our carpals and tarsals, so the bones in our ankle and wrist, those are those guys. As you can see illustrated here, we have a look at the tarsal bones right here. The cuneiforms are a great example. Following that, we have flat bones. These are easy to think of because they don't have much shape to them. It's going to be things like the ribs, the scapula are considered flat, even though they're they're a bit closer to irregular. And our cranial bones are pretty flat as well. Then there is irregular bones. This is something like the vertebrae, right? The vertebrae are very strange looking, and irregular bones tend to have relatively complex developmental process, which is why they end up like that. So, for instance, your average vertebrae contains at least 5 different developmental areas in them. And then we have sesamoid bones. These guys typically are flat bone. They're kind of flat, but the key to them is that they are formed within a tendon. So the biggest one everyone knows of is the patella. We have one on each leg, the kneecap. But there's also sesamoid bones in the feet. There's sesamoid bones in the hand. And a lot of extra bones that can randomly occur in development, they tend to be sesamoid as well. So, the basic structure of a bone. We have 3 main components. You have the epiphysis, which tends to be the articular end of the bone. So, using our example here of the femur, our epiphysis really is just this top portion here. All right, the metaphysis is where the bone starts to widen out. All right, and the diaphysis is going to be, at least for a long bone, the thinner, longer portion. So really the way to think about it is the diaphysis is the tubular component of a bone. The metaphysis comes off of the diaphysis and begins to widen out. And then we have the epiphysis at the end, where the articular surfaces to other bones tend to be. When we're looking at bone as well, we have a radial circumferential type division as well. Okay, so the outermost layer of the bone is the periosteum. You then move inside through the periosteum, and we're at the endosteum. The endosteum is the final layer there, because then you're into what is termed the medullary cavity. This is where bone marrow resides. Okay, so in our example here, you see yellow bone marrow. Yellow bone marrow is primarily associated with a lot of the non-axial bones, especially in adults, and is primarily associated with diaphysis. Now, you'll also see red marrow here, at least in the femur. Red marrow, there tends to be more red marrow in the metaphysis to epiphysis region, while yellow marrow kind of hangs out in the middle. Every bone is highly vascularized, and this is important to recognize because, again, bone is the site of blood cell production, right? That occurs in our red marrow. So our bones are highly vascular, which is also why when a bone like the femur breaks, the break can cause a lot of bleeding, right? It's also why there tends to be very large arteries next to larger bones, like the femur and the femoral artery, the humerus and the axillary and brachial arteries. So when it breaks as well, it's also possible for those external arteries that are very close to be damaged as well. But bone does require a lot of nutrition because, again, it is making a lot of stuff and it's constantly remodeling, which we will again talk about in the future. When a bone has disruption to its vascularity, it undergoes what's called avascular necrosis, sometimes also referred to as osteonecrosis. And then you can have kind of a very similar other thing called a bone infarct, which is, again, there's minor differences between them, but for our purposes, they're all kind of the same thing where bone has experienced ischemia, all right? And there's various different findings, etc., with that. But it is and can be incredibly detrimental, especially for a bone like the femur. We can have avascular necrosis of the femoral head. Typically happens in childhood, and it's called Legg-Calvé Perths, and it can cause permanent deformity of the femoral head, which leads to all sorts of other long-term complications and can potentially, require somebody to have a joint replacement at a much, much earlier age than they normally would without. So, you see this diagram here, and it's kind of showing us our cross-sectional look at the bone. Within bone itself, it's really made up of osteocytes. These are cells, okay? So osteocytes are the primary bone cell, right? Passing through and around, you're going to have essentially nutrient arteries and their accompanying veins supplying nutrients to these cells. They're basically, the same concept as like a capillary. Now, when we look at the bone matrix, now this is the inorganic component of bone. It's primarily made up of things like calcium and phosphorus, and that's what really gives bone its hardening. And this ties us into the idea that bone is also incredibly important for storing certain substances. And again, calcium, phosphorus, etc., all incredibly important for bone. And we can get a good idea with certain diseases that affect bone by doing blood tests to look at calcium and to look at things like phosphorus. There's two other important cells that we want to talk about as well. Those are osteoclasts and osteoblasts. So the easiest way to differentiate them is to think of blast being building. Okay, so B and B, blasts build. All right, it seems a little weird to think that, like, you would think of blast as like blowing something up, it's destroying it, but not for this purpose. You should think of blast as building, and osteoclasts, they break down bone, and this is a very important concept that we haven't really talked about much yet. But tissue in the body is often able to undergo some form of regeneration and some form of adaptation to stress put on it. And that is what we see with the interaction of osteoclasts and osteoblasts, right? As the body has more stress put on it, the bone is loaded more, you see greater remodeling, and you see the bone become slightly thicker, right? And in the same concept, if, for instance, if you've ever broken a bone and had to be put in a cast, you stop putting stress on that bone, whether it's because you're not walking on it anymore or you're not using the muscles that are attached to it, osteoclast activity will be higher and there will be slight bone degradation. And this is because the body does not like to hold on to tissues that are metabolically active that it doesn't need to hold on to. This whole concept of how bone adapts to stress is called Wolff's Law. Okay, so essentially, the more you load a bone, the bigger the bone will get, within reason. So looking here, next we have some terms that are describing various features on a bone. You can obviously go through all of these on your own. They're relatively straightforward, but in general, the generalized term to talk about where anything attaches to a bone, you just call the apophysis. Okay, so apophysis. Okay, so the apophysis is just the general term for where anything attaches to a bone. Not to be confused with epiphysis, it's the apophysis. All right, so oftentimes some of these are also used interchangeably, and some of them have, very traditional ways to think about them. So this here is showing us our primary bone cells that we talked about. Again, remember, osteocytes are the primary bone cell. Osteoblasts, they form matrix. And osteoclasts, they resorb bone. Osteogenic cells, they're just a stem cell. They differentiate and give us the various other types of cells depending on need and what is being signaled. So we've already kind of talked about this, so I'm going to go through it. Another thing to talk about is the osteon. So we'll see this concept in muscle as well, but there's a kind of smallest structural unit of bone, and we call that the osteon. There are concentric rings. Okay, so as you see here, the osteon is surrounded by this ring. This is just various bone tissue components, primarily made up of matrix. And that matrix is called the lamella. All right. And this is for compact bone, by the way. Spongy bone or trabecular bone is going to be a little different, but compact bone is primarily where a lot of the strength for bone comes from, whereas the spongy or trabecular bone is where a lot of the marrow is stored. Within each osteon, though, it's very important to recognize we have a set of artery, nerve, vein, and sometimes lymph node. Okay? Again, lymph node, very important for lymphocytes. So if you end up with something like a bone infection, you want lymph nodes in your bone because lymph nodes, well, not lymph nodes, but lymphatic vessels are where a lot of our lymphocytes hang out, especially T lymphocytes and the antibodies from B lymphocytes. So on top of the ability for standard leukocytes, the standard white blood cells, to be able to get here via the arteries and veins, we need specialized lymphocytes with our B T cells and our natural killer cells. So trabecular bone, instead of being this dense set of osteons that are put together, we have these trabeculae. So trabeculae are like these scaffoldings, right? They're kind of arranged a little randomly. They're like a lattice. And this helps provide bone with the multi-directional strength. Okay, this is very important, especially using the example of the femoral head. We can get a lot of different stresses through the femoral head that aren't necessarily directly into the ground, right? So when you're walking, for instance, if a person is walking, so we're looking at this guy from the side, you have 1 foot forward and the other foot's back, right? You're not loading the stress straight down in this instance. You're actually loading the stress in that direction there, the second arrow that I drew. It's very important then that we have trabeculae because this allows us to adapt and strengthen bone in these non up and down directions. All right, so looking at different types of bone injury, typically the normal bone injury everyone knows of is a fracture. We can classify fractures in many different ways. So the first primary thing that we talk about with a fracture is whether it's open or closed. Closed fractures are exactly as it sounds. They stay inside of the body. Open fractures will actually result in bone being exposed to the body. They tend to be much more severe and have other soft tissue injuries, and you're very at risk for things like large artery or vein damage. We can have transverse fractures. These are the typical fracture that, just goes straight across the bone in a transverse orientation. They can be associated with impaction. We see transverse style fractures happening with compression fractures, especially of like the vertebrae. Then there's spiral fractures. Spiral fractures are basically, they're associated with twisting. Comminuted fractures. Comminution is basically a term to describe the bone being broken into multiple pieces. These are often associated with trauma, right? So car accidents, things like that. Impaction fractures are similar to a transverse. They're a little different, but the idea is that the force is only delivered from one direction. Green stick fracture, this is only partial, and there's oblique fractures as well. So oblique and green stick fractures, those two guys tend to be more associated with kids, green stick especially, because bone has a lot more collagen. So in kids, bone's a little bit more bendy. So a green stick fracture, you're much, much more likely to see happen in a child. There's another type of fracture that's not listed here. It's called a torus fracture. It's kind of like a mix of... So if we do this... So if I'm drawing a bone here... So what basically happens is the bone collapses in on itself. And this is also, again, associated in kids. It's called a torus because it looks like the base of a like Greek pillar, okay? So bone formation. We have two main types of bone formation. There is intramembranous, and there is via the epiphyseal plates. Regardless, bone typically follows a cartilage template. So as the cartilage is created, enchondral, by the way, is the epiphyseal plate one. That's the term I couldn't remember. As our bone grows, whether it's growing longer or wider, collagen comes first, and then the osteocytes and other cells move in to replace the cartilage with bone tissue and matrix as well. So with intramembranous ossification, these are associated with the bones of our skull and our clavicles, and we can have a condition that's actually a dysfunction of this. That's called cleidocranial dysostosis. All right. So cleido, clavicle, cranial, head, and dysostosis is just dysfunctional bone formation. So with that, then we have enchondral ossification, and this is the very typical long bone style. So you have the epiphyseal plate growing, and that's the growth plate, right? So as a kid gets taller, their bone is slowly replacing the epiphyseal plate. And the primary condition associated with dysfunction of this is called achondroplasia, which is commonly referred to as congenital dwarfism. Okay, so that's why people that have that condition, they tend to have short legs, short arms, but their head is a normal size. Whereas if we come back and talk about cleidocranial dysostosis, they actually have a slightly smaller head. So bone repair, real basic, right? So we have a fracture in the bone. Just kind of like the same concept occurs with clotting, you need to stop the bleeding. So bone has a hematoma that forms. The bleeding typically stops within 24 to 48 hours, and a callus will begin to form. The blood tissue is kind of recycled out, and there's temporary structures put in place here. It's not very strong, and this could break very easily. There's going to be hypervascularization, repair of the vasculature. That's kind of the first step here as well as new microvasculature like capillaries and whatnot being extended off of the newly repaired vessels to again start supplying nutrients for the fibroblasts that kind of come in first. Osteoclasts technically come in first, and they remove the damaged, destroyed bone. Then we kind of get a combination of chondrocytes, fibroblasts, osteoblasts, etc., and they really form and start to shore up that callus. And then the osteoblasts really set to work and start to build a new bone in its place, right? It is not uncommon, at least right after a fracture, after it's fully healed, that the area around the fracture is actually has thicker bone, right? That will go away eventually since it's not that crazy. So talking about exercise, nutrition, hormones, and calcium. So exercise, as we talked before, Wolff's Law, when you put stress on a bone, the bone will get larger. Okay, and this is, again, it's just needing to be able to support itself better, which is incredibly important to ensure that when the bone is experiencing constant stress, it doesn't fracture from insufficiency. And that's why you often see like a stress fracture type situation, specifically like a March fracture, where you have one of the metatarsal bones have been put under a lot of stress, and they eventually fracture. It's actually relatively common in individuals who go off to basic training that have not done heavy equipment hikes. You know, they're suddenly putting 30, 40, 50, 60 pounds of equipment on their back, and now they're marching, for 20 miles, right? That's a new stress. They've never experienced it before, and now they're doing a lot of it. So the bone doesn't adapt properly, and boom, the bone breaks. Nutrition, incredibly important. Two big things to talk about with nutrition is calcium and vitamin D's relationship. Vitamin D is one of the fat-soluble vitamins, along with A, E, and K. We can synthesize our own vitamin D, and we can also get it from food sources. But the primary way we get vitamin D is from sunlight, and it's incredibly calling it a vitamin, it's not wrong, but vitamin D really needs to be thought of as something closer to a hormone on its own. It has its hands in so many different bodily functions. We know that individuals that don't have enough vitamin D, they're at greater risk for developing conditions like depression, or even a quote-unquote more temporary depression like seasonal affective disorder, where you're stuck inside during the winter and, your mental health kind of suffers from that. But then the moment, the snow goes away, the ice goes away, and you're able to go back outside more often, you're wearing short sleeves and shorts, and you're getting more sunlight, the symptoms go away, right? So it also plays a major role in bone health. Vitamin D kinda is the trigger that allows our body to actually use calcium. Without vitamin D, we can't really absorb calcium. And since calcium is a mineral, we definitely do not make calcium. Calcium is a must-have in the diet. It can be supplemented relatively easily, and you'll actually commonly see calcium supplements also having a vitamin D supplement attached. Very, very, very common, especially in individuals with conditions like osteoporosis, where they have reduced bone density, which can occur for various reasons. It could be part of the natural aging process. It could be pathological, or it could just be due to disuse, which again we talked about before. When you fracture a bone and you're put in a cast for 2 months, you lose mass of the bone, you lose mass of the muscle, etc. So this interaction is incredibly important. And another important thing, it's not as big of a deal, but vitamin K helps with osteoblast function. But looking at this list here of calcium, vitamin D, vitamin K, magnesium, fluoride, and omega-3 fatty acids, I would also add one more thing, which is phosphorus, because again, we don't typically have issues with phosphorus in our body. It's very, very abundant in foods, etc. But looking at that list and you include phosphorus to it, you now have a list of pretty much every molecule that is important for maintaining bone health right there, right? But again, phosphorus is probably the least important on there because, again, it's so easy to intake phosphorus. Now looking at hormones. So hormones have a massive influence on bone. Primarily looking at, I'm going to spend some time talking about the interaction of parathyroid hormone and calcitonin. Parathyroid hormone is aptly named because it's secreted by the parathyroid gland. You might sometimes see it abbreviated into one word as parathormone, but that's just literally removing like 2 letters. So I don't quite know why people do it. But parathyroid hormone actually causes an increase in osteoclast action, which means a breakdown of bone. Calcium gets released and is then reabsorbed from the blood by the kidney. All right. This causes an increase in calcium levels in the blood. It's actually very common to see some absorption with people that have excess parathyroid hormone at their distal fingertips, which, they're small bones, so it becomes easier to see kind of the scalloped appearance that can happen there. On the other hand, calcitonin is secreted by the thyroid gland. So it's interesting that parathyroid hormone comes from the parathyroid gland while calcitonin comes from the thyroid, because these glands are right next to each other. In fact, the parathyroid gland is on the posterior aspect of the thyroid itself. Calcitonin, though, inhibits osteoclasts, specifically inhibits osteoclasts. It doesn't go out of its way to do anything to osteoblasts. And this allows, if you have normal osteoblast function, if you're inhibiting osteoclasts, you're going to have a net positive in calcium, which will reduce blood calcium levels. The other hormones that are listed here, they pretty much are all metabolic adaptations, and they're things associated with growth, right? Especially growth hormone and the sex hormones, they're anabolic. They're all about building tissue, right? And thyroxine is the primary thyroid hormone that is active, and it stimulates increases in metabolic activity in every tissue, essentially. I believe the thyroid hormone actually has receptors on just about every cell in the body. So it's a very, very, very powerful hormone. And when we talk about the endocrine system, you'll see why. So really, the calcium homeostasis is this interaction of our diet, ensuring that we intake enough calcium, ensuring that we have enough vitamin D, and ensuring we have enough vitamin K. There's going to be the interaction of our parathyroid hormone and calcitonin levels as well. So all of these things kind of come together to give us this balance of calcium. And it can be a very easy to overlook issue in health. All right, so back to our basic breakdown of axial versus appendicular. Our axial skeleton is going to essentially be literally the axis of the body. That's going to include the skull, the facial bones, the vertebral column, to include the sacrum, and it's going to include our ribs and the sternum. Okay? Everything else outside of that is considered appendicular. So our scapula, everything in our arms, our pelvic bones, except for the sacrum, because again, the sacrum is considered part of the pelvis, but it's it's axial, and then our legs. So going through all of this stuff here, I'm not going to spend much time identifying, random bones, and later on in the muscles, I'm not going to spend all that much time talking about these things because they're pretty self-explanatory for identification purposes. But it is important to recognize the names of bones because you'll often see other structures associated with them, okay? So, all of this. All right, so we're now going on to muscle tissue, and we were kind of exposed to a little bit of it last week talking about the cardiac muscle. Now, remember, cardiac muscle is different than skeletal muscle. Cardiac muscle, while being striated like skeletal muscle, is involuntary, and it's primarily controlled by the internal pacemaker of the heart called the SA node, whereas skeletal muscle is controlled by the brain, and it's controlled under conscious effort. All right. We have reflexes that do occur, and we will talk about reflexes at some point, but primarily skeletal muscle is an active decision, right? I decide that I'm going to get up and walk across the room. And the brain, while a big part of it, we don't have to specifically sit there and think about how we do it. Our brain automatically kind of sends the right signals, and that's part of the motor learning process. So, again, you can kind of see the breakdown of the different muscle tissues here. At the very top is skeletal muscle. You can see these striations pretty well. Middle is smooth muscle. It's not striated, which is a big important piece. And then here with the cardiac muscle on C, we get an actually decent look at the connecting structures between the different cardiac muscles called the intercalated discs and their gap junctions, right? That, if you recall, is how signaling travels through cardiac muscle. The heart can beat on its own without the brain connected to it. Now, the brain is connected to the heart via the autonomic nervous system, but we will get into that in later aspects of the course when we talk about the nervous system. But you can technically remove the heart from the body, and it can technically beat on its own. Now, skeletal muscle requires some form of neuronal input. There is 3 basic division layers of the gross specimen of skeletal muscle. You have a epimysium, which means upon the muscle. It's a layer upon the muscle. The epimysium will then give us the next layer is the paramysium, and then we have the endomysium. So you can kind of think of the epimysium surrounding the entire skeletal muscle. The whole muscle is surrounded by one layer of tissue. Then the muscle is further subdivided into something called a fascicle. Fascicles are bundles of individual muscle fibers. Okay? This is surrounded by the perimysium. And within each individual muscle fascicle is our individual muscle fibers, which are surrounded by endomysium. Now, we do have further divisions. Each individual muscle fiber, a key thing to remember, has a sarcolemma that is upon it and is a key thing for muscle contraction. But the individual muscle fiber is then broken down into the sarcomere, which is the smallest contractile unit, very similar to the osteon we talked about earlier being the smallest functional unit of bone. The sarcomere is the smallest functional unit of muscle. So remember here with cardiac muscle, the signal travels via the intercalated discs to the gap junction and through the desmosome to travel into the next cardiac muscle. For smooth muscle, though, we have what's called a motor unit. The motor unit consists of a motor neuron, giving off many different axons to muscle cells, okay? So motor units can vary in size, and typically smaller motor units are associated with fine dexterity type movements like writing, whereas large motor units, meaning that the motor neuron innervates a lot of muscle fibers, are associated with large gross movements, something like innervating the quad muscles to extend at the knee. So, getting down into the meats and potatoes. Again, the sarcomere is the smallest functional unit of muscle. It is made up of myofibrils, and these myofibrils are made up of thick and thin filaments. The thick filaments are myosin proteins, and the thin filaments are actin protein. These filaments, myosin, kind of grabs onto actin and pulls on it. All right. Now, there's also two other proteins that we have to talk about, which are troponin and tropomyosin, and they actually regulate the ability of myosin to pull on actin. This idea of myosin pulling actin is called the sliding filament model of contraction. The important thing to remember at the neuromuscular junction, where the axon ends at its synaptic terminal and interacts with the muscle, it has to release a neurotransmitter, which is acetylcholine. So as our transmission travels down the axon, so axon, our action potential propagates down the axon, it reaches the synaptic terminal. At this synaptic terminal, there will be a reaction that causes the release of calcium. The presence of calcium here causes the vesicle containing ACH to then exocytose and release acetylcholine, ACH, into the synaptic cleft. So the cleft, remember, is this space here. Cleft. Kind of running out of space. Should have made a couple extra lines. But the cleft is this space here where my mouse is. And the ACH travels across and then binds to the acetylcholine receptor. That then causes the sarcolemma of the muscle to release calcium. Okay? And we'll talk about what happens there in a second, but there's one more step to talk about here at the neuromuscular junction. ACH has to be removed. We do that with a enzyme, aptly abbreviated ACHE, acetylcholine esterase. So the ACH is bound to the muscle. ACHE comes in, pulls ACH out, and it's then all recycled. Okay. It could be broken down to be used for other stuff, or it can kind of be recycled to make more acetylcholine. So that's everything that kind of happens here. Calcium, the action potential comes down the axon, stimulates a release of calcium that stimulates the release of vesicles containing acetylcholine. Acetylcholine is then exocytosed from the axon, and the vesicle obviously ruptures. And then the acetylcholine traverses the synaptic cleft, joins up with the receptor on the muscle fiber, and triggers the release of calcium in the sarcolemma. Acetylcholine esterase then comes into the cleft and it shuts down acetylcholine's action, removes it for recycling. Now at the muscle itself, calcium is now also released from the sarcolemma. All right. So the action potential continues on through the T tubules, which again is another component of muscle cells that kind of connects the different pieces of the sarcolemma. And this causes further release of calcium within the muscle now. This calcium binds to the regulatory protein troponin. Okay, this allows, it binds to troponin so that it can move tropomyosin. The myosin head, remember now, the primary sliding protein, is now able to bind to actin. Okay, so troponin and tropomyosin sit on top of actin and block the myosin binding sites. With calcium binding to troponin, it allows tropomyosin to move out of the way, and myosin will then grab onto the actin and initiate what's called the power stroke. So the binding of myosin to actin requires one molecule of ATP, and then the release of myosin from actin requires a second ATP. The whole concept here, though, is that we essentially have this binding here, right? Each myosin chain has multiple different heads to it, and as it pulls actin, more and more heads can attach to actin, and eventually the actin has shortened as much as it possibly can, and muscle cannot contract any further. Conceptually, the same thing kind of happens the other way, where there can be very minimal contraction because there's not enough myosin heads attached, right? So this means the muscle's in a weak position, whereas in this scenario, if all of the binding sites can be taken up, the muscle's in a very, very, very strong position. Now, at the whole muscle level, not all muscle fibers contract at the same time. And there's one major principle for this. It's called Hahnemann's size principle. And it basically tells us that smaller motor units will contract first. The body wants to use the least amount of energy possible to cause a contraction. So if we have two motor units where one motor unit contains a neuron with 10 muscle fibers and another motor unit contains a neuron with 50 muscle fibers, the difference in ATP usage there is massive, right? If every individual power stroke of each individual myosin head requires 2 molecules of ATP, you're essentially using a fifth of the molecules with our smaller motor unit in that example. You know, the one neuron with 10 fibers. Now, if that's not strong enough to create the movement that's necessary, that motor unit contracts, and then the next size up, then the next motor unit kind of contracts, okay? And so the body's doing this in the with the desire to conserve as much ATP as possible, okay? And in the exercise physiology world, we actually can look at training that factor. It's called rate coding and motor unit recruitment, and you can actually not fully, because the size principle is a relatively good model. It's not, you know, the end-all be-all, but as the body has memory of force that needs to be produced, if it can say, let's say the body only needs 100 muscle fibers to create a movement, right? In somebody who's never done that before, you know, it's going to relatively follow the size principle. You'll get your 10, you'll get 50, you'll get 70. Oh, now we've done a whole lot, right? Now we're talking 140 different muscle fibers, and we only needed 100. Well, the body might, you know, through experience, through learning, motor learning, will actually say, you know, forget the 10, forget the 40, forget the 70. I'm going to go ahead and activate the motor unit that has 100 muscle fibers. And suddenly it's the exact necessary force necessary for it. So there is a learning component to muscle activation, but for the basics of learning, we do talk about following Hahnemann's size principle, which again is, it's not a law of any kind. It's not necessarily the whole story, but it's a general rule for the idea of the nervous system recruiting smaller to larger motor units in an effort to conserve ATP. So again, as we talked before, our second molecule, after the power stroke occurs, our second molecule of ATP will bind to the myosin. The myosin head will detach, and if muscle contraction needs to cease, right? So in this case, if acetylcholine is no longer binding to the muscle at the neuromuscular junction, calcium will stop being released. If calcium is stopped releasing, myosin is no longer able to access the binding sites on actin, and the muscle is now said to be in a relaxed state. To fully actually lengthen a muscle, we typically talk about actions having a agonist and an antagonist. So if we're flexing our arm at the elbow, where, you know, flexion of the elbow is bringing our wrist closer to our shoulder, like you're doing a bicep curl, to fully relax out the bicep back to its original position, we essentially have to do one of two things. One, you just let gravity pull the arm back down. That's not going to necessarily be comfortable, right? But we can use what would be called the antagonist muscle to the bicep, which would be your tricep muscle on the posterior arm. And so then the tricep muscle has these muscles have these relationships to help not just return the body to its normal positioning, but also help control how the gross anatomy of the body actually moves. And this actually is very, very, very important for protecting articulations. Next, looking at naming of skeletal muscles. So really, skeletal muscles often have great names, right? They are often named for the actions that they do, what they attach to, what they're next to, or kind of any combination of the above. For instance, we can talk about their shape as well. That's another good one. Deltoid is a, deltoid shaped muscle. It's triangle-like. The trapezius kind of looks like a trapezoid, right? When you look at the diagrams of these muscles later on. Biceps, triceps, those guys are named for the number of heads that the muscle has. Now, it's important to remember that in a muscle like biceps, right, you have two muscle heads that share a common tendon. Their origin is different, but their insertion is going to actually be the same tendon. And the same applies to tricep as well. These muscle fibers, they tend to, if they're on different heads, they might run in different directions. They might allow the muscle to do a slightly different action. Like, for instance, the deltoid. The deltoid has the capabilities to be active for arm abduction, so moving the arm away from midline, arm flexion, so moving the arm straight out in front of you, and arm extension, right? It can play a role in all of those things because it has three directions of muscle fibers that go in all of those directions. A great example of, a combination of those, we have muscles in the forearm, like the extensor carpi ulnaris. There's extensor carpi radialis, right? There's extensor carpi radialis longus and extensor carpi radialis brevis. Now, when you're talking about long and short, brevis meaning short, they're actually not talking about the muscle belly size, but they're talking about the tendon length. So we've now, you've got this ultimate combination of extensor carpi radialis longus. That right there is about as detailed as you can get for naming a muscle. You know what action it does. It extends. You know that it's attached to the carpals, so it's extending the carpals. Radialis means that it's associated with the radius side of the arm, so the thumb side of the arm, or in anatomical position, that would be the lateral arm. And longus, you know that there's another muscle that does the same thing as it, but this one specifically has the longer tendon. All right. Now, we're not going to get into major differences between those muscles, but those two muscles actually do, slightly, very, very minimally slightly different things. And it's because they attach to different points on the carpals, but the point still stands, right? So, big thing to think about with muscle action. We're now talking on the gross level. I've mentioned this idea of agonists, antagonists. There's also another thing to talk about called a synergist. That's a muscle that assists the agonist or prime mover in performing an action. So if we're talking, again, going back to the idea of elbow flexion, we really have three big muscles to look at there that are prime movers and synergists. If we're talking about straight elbow flexion, you've got your biceps brachii, your brachialis, and your brachioradialis. All right, all three of those guys are incredibly, incredibly important for the ability to move our forearm, and they kind of attach to these various different points as well. So the bicep, it, by way of its direct tendon and its aponeurosis, attaches to both the radius and the ulna. The brachioradialis comes from our upper arm and will attach to the radius, hence the name brachioradialis. And then brachialis is deep to our bicep, but it will attach primarily to the ulna on the coronoid process of the ulna. And all of these guys, they flex there, right? Each one of these muscles can, slightly add little nuances to it, but the idea is that they work together to better control the motion, and they work together to better protect the joint. So again, I'm not going to spend much time talking about the details of all of these muscles, but it's important to remember that there are a lot of muscles in the body. They all have their own origins and insertions. Another way to think about origin versus insertion is the origin generally will be talked about as the attachment point closest to the center of mass, while the insertion typically is taught as the attachment furthest from the center of mass. Okay, that's very easy to think about when we talk about the arms and legs, for instance. But when you get into trunk, you talk about what's closest to midline versus what's furthest from midline. And again, that's a general rule of thumb. There are a couple muscles where anatomists don't necessarily follow that rule, but it's a general rule that can easily guide you. Now, I would take time for you to learn all of these muscles, especially the ones highlighted here. There are a lot more muscles than what's listed here as well. Another thing to consider is that every single one of these muscles has a nerve supply. So when you talk about performing neurological testing and seeing that people have damage to like the radial nerve, for instance, you see very specific symptoms associated with nerve damage and not muscle damage, right? So again, this is some naming credentials. We've kind of already talked about all of that. Now, moving on to joints. Now, every bone has some form of articulation for the most part. Like the hyoid technically doesn't directly articulate with anything, but it's attached to other bones via the hyoid musculature, which is very extensive. We have kind of multiple ways to classify joints. The first one is structural. So there can be joints that are fibrous, meaning there is fibrous, dense, well, not necessarily dense, but fibrous connective tissue holding them together. You can think of these as like the sutures of the skull. Cartilaginous joints are joints where the bone articulates with another bone via a piece of cartilage. Great example for this is the ribs, it's the anterior rib. Now, the posterior rib is a synovial joint where it articulates with both the costal facet and the transverse process of the thoracic vertebrae. But the anterior ribs all articulate with a piece of cartilage that's then via the various types of rib, that cartilage is then connected to the sternum. Okay, so that's a cartilaginous joint. And then synovial joints. These are the typical freely moving joints that we think of. You talk about your knee, your hip, etc. They have a joint capsule that is filled with synovial fluid. This fluid is incredibly important for the ability of the joint surfaces and their hyaline articular cartilage coverings to freely move in a relatively low friction environment. Joints can also be classified by function. So there's things like synarthrosis, amphiarthrosis, which are slightly movable, diarthrosis, which is freely moving. So, we talk about something like the shoulder. It is both a synovial joint and a diarthrosis. Okay, joints can have both. They will have both a functional and structural classification. right? So again, a synarthrosis. A great thing to think about a synarthrosis is a adult's skull. The adult skull does not move. Okay, no matter in a healthy person, that is, a adult skull should not move when you push on it, right? Now, if I come up to someone and I tell them to, sit still, and I'm going to move their arm around, that's a diarthrosis. That's freely moving. So, fibrous joints, again, this is going to go through the anatomy of those, but the idea is that there is a fibrous connective tissue holding the bones together. The primary thing we think about is the sutures of our skull, holding each of the skull bones together. But there's also another type called a syndesmosis that is between the radius and ulna, as well as the tibia and fibula. All right, so there is a interosseous membrane that connects those two bones together. And you can actually sprain that membrane because it is a connective tissue structure, because when we talk about sprain versus strain, a strain is for something that's muscular in nature, whereas a strain or a sprain is connective tissue. Another important thing to talk about is the teeth. When our teeth are in the mouth, they are actually in a joint called a gomphosis. It's just the I'm not sure about the Latin root for that, but it's the joint where the tooth articulates with either the maxilla or the mandible. Cartilaginous joints. So a big one to talk about is our pubic symphysis. That's another important one. It's where the two pubis bones essentially articulate together. It's incredibly, incredibly important for, especially in females, for pregnancy, right? That the fact that there is a joint there allows the pelvis to kind of expand a bit, and that is incredibly important when you have a fetus developing inside of that area. If that did not move, the fetus would have to either be smaller, or we would essentially be breaking bone or rupturing ligaments and other connective tissue structures just to give birth, right? And damage to the pelvis is not good. A lot of pelvic issues are linked to a lot of genitourinary problems as well, and people can have extensive internal injuries if enough force is required to actually cause these joints to pull apart. Now, our main guy, synovial joints. These are the most common joint in the body. You see here a generic synovial joint. We can kind of pretend that that is like a knee, for instance. But the ends of our bone that articulate with synovial joints, they're covered in a hyaline articular cartilage. And the total joint surface is surrounded by the synovial capsule. And that capsule, the synovium itself, actually creates synovial fluid, and it sort of lubricates the connecting joint pieces and helps keep friction to a minimum. Problems with synovial joints are associated with a lot of inflammatory and non-inflammatory arthritic conditions, stuff like rheumatoid arthritis. Specifically, rheumatoid arthritis is actually a autoimmune condition of the synovium itself, so the body will actually attack the synovial membrane. And it's very important to recognize that not all of the bone inside of the synovium is actually covered by articular cartilage. So you'll actually typically see some types of arthritis start to affect this area up here that is sometimes referred to as the bare area of the bone. It's also important to recognize that since I mentioned arthritis, that there are many, many, many different types of arthritis. They're not just necessarily the generic arthritis that we think of, the osteoarthritis. That's our bare bones, basic degenerative arthritis. It's stuff that happens normally from aging. It's stuff that happens from deficiencies in biomechanics that can be associated with stuff like trauma and previous injury, right? And contrary to popular belief, all of the literature that exists tells us that osteoarthritis itself is not necessarily in a normal person. It's not wear and tear, right? If you've never injured your knee in any way, yet you develop osteoarthritis, it's not wear and tear. It's normal. Okay? It's important to recognize that basic osteoarthritis is normal and is associated with aging. It's not a major problem. It can produce pain. It can produce stiffness. But we have great treatments for basic osteoarthritis. And one of them is something anybody could do at any point: exercise, right? You don't need anything fancy for it. But I'll get off my high horse with that. There are pathological arthritises, though. And that's stuff like psoriatic, ankylosing spondylitis, rheumatoid arthritis, like we talked about earlier, and reactive arthritis. Those are kind of the big four. I mean, there's also more than that as well. There's neuropathic, there's arthritis that's caused by infection, etc. But in a normal joint, it's relatively normal. So, talking about types of synovial joints, they can be described based on the way they move. These are the big main dudes we see here. So a pivot joint makes a lot of sense. So it literally pivots. The perfect way to think about this is the connection between C1 and C2, the first two cervical vertebrae. Those are sometimes referred to as the axis and the atlas. The axis sits on top of C2 and rotates around a special process of C2 called the DINS, and that's a pivot joint, right? A ball and socket joint, these typically are the most freely moving. We see those a lot in the hip and the shoulder. They have the greatest degrees of freedom for movement, meaning the number of planes they can move in is much larger. Following that, we have condyloid joints. They're not as freely movable as ball and sockets. They only have 2 degrees of freedom. But a big thing that we see with condyloid joints are like our metacarpal phalangeal joints, so like your knuckle joints, and the joints at the wrist. Hinge joints, we have 2 really, really big ones that everyone knows of, our elbow and our knee. Those 2 joints kind of have, they look a little different, but embryologically, our legs are actually a reversed version of our arms. So if we were to flip our legs back around and then fuse the patella to the tibia, the patella would essentially become the olecranon process of the ulna. It's rather interesting. The body is not it comes up with some, biology has come up with some very clever solutions for things, and it's kind of, the whole old saying of, if it's not broken, don't fix it, maybe modify it a little like they did there. But another big important type to mention is the saddle joint. That's what allows us to perform the action of opposition of our thumb, right? And that gives us a big edge over many other animals for the ability to do things like write and easily grasp things. And then the last type to mention here is plane joints. Sometimes these are referred to as gliding joints. You see these in the carpals and tarsals, and those joints will actually, they slightly move on one another, and they don't provide a ton of motion, but they allow the ability to, especially in the feet and hands, to kind of contour those things, especially in the feet, very important for our ability to walk on uneven surfaces, as an example. If our entire ankle was very rigid, we would have issues, walking on anything that wasn't flat. So, going through motions here, it's very simple. The basic way to think about it, flexion in general is increasing the joint angle, and all of these are in reference to the anatomical position. So flexion is increasing the joint angle, extension is decreasing joint angle. We can also have what's called hyperextension. So if you're in a flexed position, right? So if, for instance, we're flexing our neck, that means we're tucking our chin into our chest, and we would then be performing extension, bringing the head back to neutral. Generally, once you get beyond neutral, though, like if we're trying to touch the back of our head to our shoulder blades, which, you can't do, but if we're trying to do that, that's called hyperextension. We can also talk about hyperflexion as well, but that tends to be associated with forced events like trauma, for instance. A lot of these other things are also very self-explanatory. Rotation, you're moving right or left around an axis. We can also refer to rotation as lateral or medial. So if we're talking about the limb, we typically use those terms. You can also use internal versus external for rotation as well. External being the same as lateral and internal being the same as medial. Another big thing to talk about is abduction or adduction. I typically say them like that instead of abduction or adduction because it's easier to understand if I'm saying the AB or the AD. So abduction from anatomical position means I'm moving something away from midline. And adduction would then be taking something back towards midline. I'm adding it back. Now, there is one other thing that's not mentioned on here, the concept of lateral flexion. We only talk about lateral flexion for structures that are midline, right? So if we're talking about lateral flexion of our torso, well, that would be bending to one side or the other, right? Instead of flexing and extending forward and back, we're going right or left. We don't use AB or adduction for that. We talk about lateral flexion. So you would say right lateral flexion, left lateral flexion. And even more detailed, if you get down to the hand, anatomically, the way that our hand is set up, the middle finger technically doesn't abduct. So it's a funky thing, but basically the middle finger also kind of officially laterally flexes. Okay. Some other minor things to talk about. Pronation, supination. So pronation means the palm faces down. And I like to think about pronation, palm down. Supination means I'm holding a bowl of soup. So my palm is facing up. I have a bowl of soup in my hand and I don't want to drop it. Dorsiflexion, plantar flexion. Sometimes you hear of plantar flexion, simply called flexion, and dorsiflexion is sometimes called extension. Plantar flexion, real simple though, you're flexing the foot in the plantar direction, whereas dorsiflexion, dorsi meaning dorsum, so top of the foot, you're flexing towards the dorsum. Now, inversion, eversion is a little bit more of a complicated motion because it actually involves pronation and supination of the lower extremity. But in general, eversion means you're taking your ankle and moving it in such a way that the big toe is now the highest toe. And if you're everting, you're turning your ankle outwards so that your pinky toe is actually essentially the highest toe. So that is essentially everything. You'll see some other diagrams that are left, some further descriptions of joints, a couple other actions that aren't all that super important for our purposes, as well as this great diagram of the knee that kind of shows a lot of these different important features of the knee joint. Okay, the knee joint is, if you look at it on a piece of paper, it looks rather unstable. But then if you really break down all of the musculature that's associated with the knee and the biomechanics of what the patella does for the knee, as well as the articular surfaces and the lateral and medial meniscus, it's actually pretty incredible that the knee is as stable as it is. Even though it is one of the more commonly injured joints, it takes a lot of energy to catastrophically damage the knee. Even when you talk about very relatively common injuries like an ACL tear, that's one ligament. You have just the major ligaments, really. You've got a anterior cruciate ligament, a posterior cruciate ligament, a lateral collateral ligament, and a medial collateral ligament, and then a posterior meniscofemoral and an anterior meniscofemoral ligament. And that's just for holding the tibia to and the femur in alignment. There's the quadricep tendon and the patellar ligament as well to hold the patella in place. And the patella plays a major role in helping regulate the biomechanics of the entire rest of the knee as well. It's kind of acts as a lever for the quadricep muscles. But that is everything for our lecture here. So as always, if you have any questions, please make sure to ask.